Today we're going to talk about something that is important to me because I am from a relatively rural area in Alabama. So we're going to talk about the role of effective telecommunications in the management of trauma care. So I'm going to start with a little scenario. This scenario starts with an actual patient that I had last year, 25-year-old female who was injured in a motor vehicular accident. She had a prolonged extrication and finally made it to a facility in Mississippi, a rural facility, which was basically a level 3 trauma center after 45 minutes of her injury. Her workup was started, and 2 hours post her accident, I get a call as the attending trauma surgeon at a level 1 institution saying that they needed to transfer this patient to me. About 50 minutes later, I accept her obviously, and about 50 minutes later, she arrives via air ambulance, and we take her straight from the helipad to the OR. We worked on her for about 45 minutes, but ultimately she died because of her injury. She basically bled to death. There was not much we could do. And she was actually pregnant, and of course we lost the fetus. And it was a sad situation, but the points that I want to make about this scenario is that, number one, she was talking to her family when she arrived at this rural facility. When her dad came in and said, how in God's name did this happen? And I didn't have an answer for her. Number two is that she was 60 minutes away from my facility. If you were to get in your car and drive the speed limit, you would have made it to my hospital in 60 minutes, not 2 hours and 50 minutes. And point three, her husband, who was on a ship in the Persian Gulf, knew about her accident before I knew about her accident. So that's why I think the role of communications for rural traumas is a very important topic. So our objectives today, we're going to discuss the various forms of communications that make up telemedicine. We're going to discuss the applications of communications into the field of medicine, specifically trauma. And we're going to touch on the future applications of telemedicine, what could be, what some potential areas of improvement are. So background. As we know in this room, trauma is the leading cause of death for individuals from age 1 year up to the age of 45. 2005, from Traffic Safety Facts, 2.7 million people were injured in the United States, with 43,000 deaths. In 2004, the worldwide motor vehicular collision statistics report 1.2 million deaths. That's over 3,000 people a day die from car accidents back in 2004. To give you kind of some scope or sizing, we've had about 4,800 people die in Iraq over 7 years. 3,000 die every day. Estimated cost is $518 billion a year, and the worldwide motor vehicular collision statistics anticipate that traffic injuries and fatalities will become the third largest contributor to the global burden of disease by 2020. This is a chart from the CDC, basically showing that from years 1 through 45 of age, unintentional injury is the number one cause of death, with some homicide and suicide thrown in there as well. This is a chart specifically talking about rural health, discussing age-adjusted mortality per 100,000. And what you'll notice from this graph is that if you're injured in a metropolitan area, whether it's large or small, your mortality rate is definitely lower than if you're injured in an area without a city, which is the far column over here on the right-hand side, or in a non-metropolitan area. So the question is, why do rural patients die more often from trauma? Well, delay in transport from the scene could be the first thing that we need to talk about. Higher vehicular speeds, higher roadway speeds obviously occur in areas that where there's less population and thus less police enforcement. Inadequate stabilization in the field or at these outside facilities. Delay in transfer to higher echelons of care, mainly by overzealous diagnostic workup, which is what the problem was in our first patient, or in the patient that I presented. And then inadequate resources, blood products, not having surgeons available, infrastructure issues, all of these types of things. Let's talk about delay in transport from the scene. This is a study by Gonzalez, who is actually my partner at South Alabama. And he received a multi-million-dollar grant to look at rural vehicular trauma. And he looked at 45,000 car accident victims over a 2-year period in Alabama, and found that if you were injured in a rural area, your chance of dying was twice that if you were injured in an urban area. And when the mortalities occurred, the mean pre-hospital time was 42 minutes versus 24 minutes in the urban setting, which obviously led him to the conclusion that EMS pre-hospital times associated with higher mortality rates in rural settings. So the question is, well, why does that happen? Well, you have to remember in the rural setting that, number one, these rural ambulances are going to be geographically isolated from other areas in the county or in the country. They're usually less well trained than their urban counterparts, and they tend to stay on the scene a lot longer than their urban counterparts. Gonzalez also looked at vehicular speeds, and again he looked at a 2-year period and linked basically crash report data and EMS patient care reports, and by extracting vehicular speeds from police crash reports, they were able to guesstimate how fast these patients were going when they were injured. And what he found is that patients who were in rural settings had a significantly higher rate of speeding than those than their urban counterparts. So we'll move on. Dr. Harrington, who is out of Brown University, Rhode Island, looked at 3,500 patients and basically divided the study group into those patients that were transferred directly from the scene, so they were injured and they were brought directly to his level 1 facility, versus those patients who were transferred from an outside facility, meaning that they were brought into a community hospital or some such and then brought in. And what he found is that the patients who were transferred in, they in general had a higher ISS, they had lower Glasgow coma scores, lower initial blood pressures, and higher mortality rates than the patients who were directly brought into the hospital. And the average time that was spent at the outside facilities was about 162 minutes. What was interesting about this study, and the reason that I put it up there, is that even though patients who were hypotensive, when they initially came to these outside facilities, they spent an average of over 2 hours at these outside facilities receiving numerous CT scans, numerous diagnostic tests, despite the unavailability of surgeons or definitive care. Delay in transfer to higher echelons of care. Svensson looked at this in 2008. Basically, it was a 6-year period, a 6-year study period in Wisconsin that evaluated the way their trauma system worked pre and post implementation of a statewide trauma system. And what they found is that the mean emergency department time was well over 2.5 hours for these patients. And it didn't matter whether or not the trauma system was in place or not. And they concluded that outreach educational efforts should focus on systematic trauma evaluations, prompt transfers, and limitations of non-therapeutic testing. The last thing I want to talk about is ATLS deviation. Certo found that in Vermont found that there were 10 preventable deaths out of 45 mortalities in rural areas, and they felt that the reason that this occurred was due to ATLS deviation. That these rural facilities had physicians, not necessarily emergency department physicians, but more like residents maybe moonlighting in facilities, maybe family practice doctors or obstetricians moonlighting in rural facilities. who were deviating from ATLS protocol. Hicks and Gilmore also looked at this, and they examined the frequency of variation of ATLS protocol at rural facilities, and basically they found that people did deviate from ATLS protocol, and that they emphasized that rural physicians need to be trained sufficiently in ATLS. So with all of that said, where does the rubber meet the road as far as telemedicine is concerned? How are we going to help all of these problems with telemedicine or telecommunications? So let's first talk about the obstacles in caring for the rural trauma patient. Number one, there's always a distance geographic isolation issue, and weather can also be an issue as well. Insufficient notification, and we can't do anything about this. We're not going to fix this with telecommunications. But we can fix the insufficient notification. We can help with the lack of resources. We can help with the insufficient numbers of personnel. We can help with the knowledge base gaps, and we can certainly improve quality assurance and improve feedback. So applications for teletrauma. And I'm going to go through a few definitions for you. Teleconferencing. This is what the business world has been using for years, where two groups or two individuals get on the telephone or on their speaker phones and they talk about things. Well, that's what teleconferencing is. Teleconsulting is the evaluation of a patient or patient data by an off-site physician. It can be a physician to a physician. It can be a physician to a nurse. It can be any kind of care provider to another care provider. Teleradiology, we're all familiar with that. That's the ability to transmit radiographs electronically to remote facilities for interpretation. Telemetry, we're familiar with that. That's the ability to monitor selected parameters remotely from the patient. We have that here in the hospital, obviously. Telementoring, this is the guidance of a physician or a surgeon through a surgical procedure. This is really where my interest lies, right here. And then, of course, telesurgery, which is the actual performance of surgical procedures by a physician who's remote from that location using robotically controlled instruments. We'll go through all of that. Okay, but first I'm going to give you some history. I always like to give you history. So telemedicine is not new. It's been around since 1959. It started in Nebraska at the Nebraska Psychiatric Institute, where they used closed-circuit TV to teach medical students neuro exams. In the 1960s, they were using this technology to perform psychotherapy sessions, to perform consults, and also to allow their patients' families to visit with these psych patients. NASA and the Lockheed Corporation used microwave technology to connect rural Native American paramedics to hospital consultants. The Mass General back in '68 received video and EKGs, blood pressure, stethoscope sounds and blood smears from outlying clinics. In Cleveland, the University Hospital in Cleveland had a connection to a small inner-city ICU for two-way television and cable sound. This program lasted for 18 months, and the reason it was shut down is, number one, they had lots of technical difficulties associated with it, but number two, the smaller institution would ignore the larger institution's recommendations. Throughout the 80s, there was decreased efforts to explore and implement new communications with medicine, probably due to costs. But a reemergence in an interest in telecommunications has come up recently. Number one, because of fewer practitioners. Number two, the internet. Number three, the technology is inexpensive. And really, and I should have put it in here, is that we as providers want to have the best quality for our patients at the larger institutions. I'm not saying that the smaller institutions don't, but we certainly are focused in on that. So, problem-oriented approach. How can effective communications help with the problems of these problems here? Well, let's go through that. Insufficient notification and delay in transport. Why does this happen? Well, basically what I'm talking about is when a patient's injured, how come no one seems to know anything about the patient until the last minute? Well, it's usually because the medics are overwhelmed, or the facility is overwhelmed, or the physician is overwhelmed. He doesn't really, doesn't have a good grasp of what's going on. Maybe there's a couple patients, pretty bad sick trauma patients that come into a 6-bed ER. That can overwhelm 2 nurses and a physician very quickly. Or maybe the physician just does not recognize the patient as being moderately to severely injured. So some solutions that we can provide for that using communications: GPS technology, telemetry, teleconsulting. So first I'm going to give you a little telemetry here. This is called the ELFstat. This is actually a device that was designed for the Army, and it's basically a high-tech litter. It's got a ventilator on board, it's got infusion pumps, it's got suction, it's got a defibrillator, it's got an ABG analyzer, it's got physiological monitoring, it's got a sophisticated power and data management system that can be logged in and logged out of computer systems. It's actually been used in the Army. This is where I was located in Kosovo. This is Camp Bondsteel, and this is Task Force Med Falcon. They're basically, they've got this patient loaded up and they're about to ship that patient over to Landstuhl. The problem with this device is that it's 165 pounds, so not exactly user-friendly, but it's got, you know, some good things to it. Global positioning is something that, you know, any General Motors vehicle has global positioning right now. And lots of other vehicles have it as well. You can get these little TomToms or whatever you want, Magellan devices to find your way around the streets. I think it's great that with General Motors, if you've been involved in an accident, your car automatically dials someone and says, hey, this car's been in an accident. You might want to send somebody out here. Doesn't make sense to me why every car doesn't have this. So that's something that we could actually work on. I just threw this in here because I think it's something that is interesting. This is a personal information carrier right here, and it's not much bigger than a dog tag, as you can see it right there. This is an Army personnel showing you that. And you know, basically it's a chip that's got your storage medium for a complete medical history. I think when in the future, when medical records are online, or not online, but everyone is forced to go to electronic medical records, having a device like this is going to be very important. You know, you can just scan that in the computer and out pops your list, and you know whether or not the patient's on Coumadin or, you know, is whatever. So let's move on to teleconsulting. And you can do this a couple ways. You can do it by email, I'll describe that, and then we'll also talk about two-way audio and visual links in the trauma bay, which is, again, my interest. So Operation Primetime, it was a satellite-based telemedicine system that was deployed in support of primary care doctors who were located remotely in the U.S. military. And its declared aim was to improve the standard of care for its patients. It was also enacted to reduce evacuations from patients who were injured, possibly, or sick, but the physician that was treating them was, you know, basically they had no experience, so they were just sending everyone out. It was also to help junior physicians in the field and to improve military effectiveness. AKO, which is the Army Knowledge Online system, which is basically the email system that the U.S. Army uses right now, has been used as a teleconsulting service for providers in 4 locations, and it's been used in 11 subspecialties: burn, derm, nephrology, rheumatology, neurology, pediatric intensive care, preventive and occupational medicine, cardiology, infectious disease, and ophthalmology, as well as toxicology. Basically, the physician out in the field types in their question, sends the email off to someone back here in the States. Within 24 hours, they are mandated to give a response back to those patients. And it actually works pretty well. I've used it once or twice when I was in Kosovo. The way it affects evacuation systems is that only those patients that really need to be evacuated are evacuated. You only evacuate the appropriate cases. So this is a kind of a schematic of a teleconsulting system, and what you can see here is you have a main camera, an auxiliary camera, you have a LCD monitor, You've got a medical camera, maybe you want to hook it up to a bronchoscope or a laryngoscope. You have a document camera. You can imagine your PAC system would be plugged into this system as well. You have a computer system to send all of this out to the network, to another facility. And you also have some audio communication so that you can actually speak to the physicians. And you can see here, this is a little stethoscope there where you can listen, and the person that's on the other end can listen as well. So this is some examples of teleconsulting. This is obviously a baby in a facility, and they're looking at this baby here, and doc here is telling them all about it and examining the patient. And probably what they're doing is they're giving some advice. Maybe this baby has a heart murmur or who knows what, and they're communicating. This guy here is Dr. Latifi. He is a Kosovo native, actually, who now works over at the University of Arizona. And he's probably the biggest proponent of telemedicine I've ever met. And basically, he set up Kosovo's system of telemedicine. It's a multi-million-dollar setup that he has over there. Basically, what they do is when they have problems with patients, they take the camera and they look at the patient, they send the x-rays, and they send the lab results, everything electronically. And someone who's a specialist is on the other end, because all they seem to have is a bunch of generalists over there. Someone who's a specialist will provide an expert opinion, and they'll implement that expert opinion. Other things, lack of resources. How can we affect lack of resources and insufficient numbers of personnel? Well, teleradiology, teleconsulting, telementoring, and maybe telesurgery, I don't know. Teleradiology, basically what you have to have is you have to have a system that sets up a way in which images can be transmitted online to other facilities. So that a radiologist can read it at the other end and send back a report. This is Major Lucene, and he's my buddy. I actually graduated with him from medical school, and he was with me in Kosovo. And yes, we actually do carry weapons every now and then. Distance, geographic isolation, and weather. Again, teleconsulting, telementoring, and telesurgery can all be used. Telementoring, what is that? Again, this is the area where I think as far as trauma is concerned, is going to have the most is going to be the most applicable, where you're basically, as an expert surgeon or a trauma surgeon, standing in or sitting in your level 1 facility in front of computer screens, where you can look at radiology and actually look at the patient via a camera, and can listen to what's going on in the trauma bay. And that doctor that's in the trauma bay, or that nurse practitioner, or that physician's assistant, whoever it may be taking care of that patient, has a headset on and a microphone on, and you can communicate back and forth with them. And and you can direct these patients direct these physicians in various mechanisms to stabilize your patient until you can get them over to me, or get them over to a higher level facility. You can also do this in the operating room. You can do this with damage control laparotomy. Dr. Coimbra talks about how he basically directed a physician through a laparotomy at El Centro, doing damage control thoracotomies and even putting external fixators on prior to transfer. This looks like just a regular old operating room light, but if you'll notice right here at the very center in the handle, there's a camera. So you can focus that in on wherever the light's focusing, and whoever's looking at the patient or the video camera on the other end sees exactly what you see, as long as it's focused in the right place. So the technology's there, it's just the infrastructure needed. This is a telementoring type thing that's already being done in laparoscopy. Maybe this surgeon here is wanting to do gastric bypasses. Well, this guy over here is walking him through it, and you can see that there's cameras mounted. They have cameras that are fed through the system. This guy over here is kind of showing you what the room looks like, and this physician can talk to this physician exclusively, or can talk to the entire room, whatever he needs to do. And then telesurgery. There's actually some work that has been done on this. Sturbis has looked at transcontinental telesurgery using a porcine model, and they did 4 nephrectomies using the Da Vinci system from 1,300 miles away and 2,400 miles from the operating room. All 4 procedures were successful, meaning that the patient didn't die, the pig didn't die, and that the kidney came out okay. They had round-trip delays from 450 to 900 milliseconds demonstrated. Don't know if that's ever really going to be standard of care, but it might be. You never know. Is it really practical for trauma patients? Probably not. I can't imagine anyone setting this up on a trauma patient and then over here doing their little thing with their chopsticks. Dr. Blake Hannaford's lab in Seattle is developing robot-type arms for telesurgery. And basically the idea is that you can take a patient that's wounded in combat, you slide them on the gurney, you fit this thing over them, and some surgeon that's nice and safe in a bunker can operate on the patient. That's the theory. Don't think you're going to be able to take care of that with that or that. But maybe that. I don't know. Maybe that. So lastly, I want to talk about inadequate feedback in education. The patient care loop must be closed for rural physicians. They want to be educated and they want feedback, and we can do this for them. We can teleconference with them, we can do grand rounds with them, we can do surgical audits, QA. This conference, for example, could be broadcast to them. There are lots of applications for education. This is actually a little schematic that I put down to kind of show you how the way the Army does it. The battalion aid station is the most basic form of care on the battlefield, and it's usually manned by a physician who may be an internal medicine doctor, maybe a dermatologist, who knows, maybe a pediatrician. Well, when they have casualties, they send them up to a forward surgical team or to a combat support hospital. Well, what the forward surgical team will give these providers here feedback about how well that patient did. How good of a job did they do taking care of that patient? Likewise, the forward surgical team will send their patients to the combat support hospital, who will then send them information back, and so on and so forth, so that you have a nice feedback loop. So the people who took care of a patient and then shipped them along know how good of a job they did so this is a way to improve quality for your patients. But there are problems with communication systems. They're expensive to implement, they're expensive to maintain, they're sophisticated, so you have to have people like Pat over there to be able to run the equipment. You have to have people that can troubleshoot the equipment and repair the equipment. And then ultimately the equipment becomes obsolete, so you're always having to update it. So those are the problems with telecommunications. But in my mind, it's a necessity for rural areas. Better programs need to be developed to make use of available resources. I mean, we have resources in our hands now, but they're just not implemented. And then with evolving technology, what we'll see is evolving technology, and we will see evolving usages ultimately. That's all I have for you. Any questions?
Thanks.